un gran amigo que vino por primera vez en México hace ya muchos años, cuando él describió la inyección de toxina botulínica para el tratamiento de la calasia. Es la primera vez que invitamos a Jay a México. Él es profesor de medicina en la Clínica Mayo de Arizona y es el actual jefe de medicina interna de la Clínica Mayo en Scottsdale. Tiene un currículum enorme, pero voy a mencionar algunos highlights. Él también fue director de la unidad de Neurogastro en el Johns Hopkins y profesor de medicina en la Universidad de Stanford, universidades ampliamente reconocidas a nivel mundial. La característica de Jay es que es innovador. Como les mencioné, él fue el primero que describió el uso de toxina botulínica en trastornos de la motilidad, pero él desarrolló, no sé si ustedes lo sabían, él desarrolló el modelo animal para hacer la endoscopía del tercer espacio, el tratamiento de la calasia con el POEM, que ahora es una realidad y un tratamiento no solamente a nivel de la calasia, sino también de divertículo de Schenker, de gastroparesia, etcétera. También ha desarrollado o ha investigado el trasplante de células madre para tratamiento de enfermedades motoras del tubo digestivo y ha acuñado términos como el YAG-A. ¿Qué quiere decir esto? Que los pacientes con trastornos de la interacción cerebro-intestino, que no le gusta este término, pero lo que hoy conocemos como trastornos de la interacción cerebro-intestino, que tienen hipermovilidad articular, disfunción autonómica, disfunción gastrointestinal y autoinmunidad. Entonces, él ha publicado más de 400 artículos, de tal forma que yo podría dar una conferencia acerca de Jay. Lo admiro mucho, es una gente brillante, es una gente muy inquieta, toma muchos riesgos, por eso está donde está. Bienvenido, Jay. Muchísimas gracias por estar aquí con nosotros.
Muchas gracias. Dr. Rami, Dr. Valdovinos, thank you very much for inviting me to this lovely city of Mérida, and as I said last night, to one of my favorite countries, Mexico. It's my pleasure today to give a talk on functional dyspepsia versus gastroparesis, and this was not my title, but was suggested by the organizers, a dilemma for the gastroenterologist. So first, I want to thank my colleagues in what we call the Gastroparesis Clinical Research Consortium. This is a group of several academic centers that got together almost 20 plus years ago now to create a consortium to study gastroparesis. Back then, very little was known about the natural history of gastroparesis, about what causes it, and what the underlying pathology is. But over the last couple of decades, I think we have made significant progress. Have we solved the problem of gastroparesis? No. I wish we had. We are still a long way from doing that. But today I will show you a few glimpses of what can be done if you study a disease systematically. So what I will talk about today is an overview of gastroparesis and functional dyspepsia very quickly, some highlights from the consortium that I talked about, but more importantly, what are the implications of these findings for patients and particularly the pharma industry, because as you know, there is a real shortage of drugs for these conditions. So everybody knows this, but again, I will just very quickly say that gastroparesis is defined as chronic nausea and vomiting or symptoms of that in the setting of delayed gastric emptying and without any structural cause of obstruction. How do we define functional dyspepsia? It can present with similar symptoms, and for much of the last 100 years, we've always thought functional dyspepsia to be very different than gastroparesis. However, there have not been as many systematic studies to address that question. So, again, formal definition of gastroparesis: syndrome characterized by delayed gastric emptying. And for functional dyspepsia, we adopt the Rome criteria, mainly. It used to be Rome 3, which has been used for most of the studies I will talk about. And now, of course, we're in Rome 4. A couple of years we'll be in Rome 5, and after that, Rome 6, and so on. But the definitions change a little bit, but the essence is the same. The practical definition of functional dyspepsia is it is non-organic, as opposed to gastroparesis, which is organic. And so everything comes down to just one thing: gastric emptying. Otherwise, the definition looks exactly the same. So if gastric emptying is normal, we call it functional dyspepsia. If gastric emptying is delayed, we call it gastroparesis. So now I want to talk to you about the study that we did addressing this issue. What is the true nature of these distinctions? And the questions that we asked in the study were as follows. It all comes down to gastric emptying, as I said. So we asked, what difference does gastric emptying make? Is symptom severity really different depending on the gastric emptying? Is the outcome different? Is the pathology different? Do symptoms correlate with gastric emptying? And is gastric emptying a stable marker for gastroparesis? So we studied 944 patients in our registry, and about a quarter of them had normal emptying, and they met the Rome 3 criteria for functional dyspepsia. The vast majority of them had the so-called postprandial distress subtype, but 2/3 also had the epigastric pain subtype. And the rest, 3/4 of the patients, had delayed gastric emptying by standardized scintigraphy. So we compared these two populations. Baseline features, not different at all. Same gender ratio, age, ethnicity, education. The prevalence of diabetes was slightly higher, at least type 2 diabetes in gastroparesis, but otherwise broadly similar. Most of these patients had idiopathic symptoms. The duration was the same. Whether the patients said their illness started suddenly was the same. Whether they had some kind of initial infection was the same. The depression and anxiety measures were the same: Beck depression, state and trait anxiety measures. So the baseline characteristics are the same. Is the symptom severity different? Nope. If you look at nausea, vomiting, abdominal pain, it's all the same in terms of severity. You look at the GCSI, which is a standardized measure for quantifying gastroparesis symptoms, exactly the same. Impact on quality of life, exactly the same. If you follow these patients, is the outcome different depending on whether the gastric emptying was normal or not? At 48 weeks, a year, and we've done this for several years after that, it doesn't matter. Very few of them improve. About 20 to 25% actually improve, regardless of whether their gastric emptying is normal or abnormal. But here is the real thing. We only should believe pathology, right? That's what we've been taught. So this is our ground truth. Is the pathology different in patients with functional dyspepsia and those with gastroparesis? And we've published this previously, and we've shown that there is a distinct pathology in the stomach of patients with gastroparesis. The most important features are not loss of nerves or fibrosis, but two important things you should remember. There is a loss of the interstitial cells of Cajal, ICC, are significantly reduced. And number two, this is accompanied by an aberrant, an abnormal profile of macrophages. And macrophages are cells that are part of the innate immunity and are important for modulating inflammation in tissues. A particular kind of macrophage, which is characterized by CD206, goes down in gastroparesis. And we think that may be important for promoting inflammation in the stomach. So we took full thickness biopsies from patients with gastroparesis, with delayed emptying, and those with functional dyspepsia with normal emptying. And as you can see here, both functional dyspepsia and gastroparetic stomachs had the same pathology. There was a loss of ICC. There was an infiltrate of a different kind of macrophage. So pathologically, they are the same. Symptomatically, they are the same. But then let's see whether maybe the delay in emptying really correlates with symptoms or not. And here's a study that we did where we took patients who had delayed emptying at baseline. So you can see the pie on the left, all in red. There were 189 patients, all with delayed emptying. And when we followed them a year later, if you go to the right side, about 42% of these patients went from delayed emptying to normal emptying. In other words, if you had stuck to this definition, you would now no longer call them gastroparesis, but you would call 42% of these patients functional dyspepsia. Conversely, if you took patients who had normal emptying to begin with, and you classified them as functional dyspepsia, and you follow them for a year, again, about 40% of them develop delayed emptying. And now you would call them gastroparesis, not functional dyspepsia anymore if you stuck to that definition. But it doesn't matter whether their gastric emptying goes from normal to delayed or from delayed to normal. Nothing happens to their symptoms. Their symptoms stay the same, which is remarkable, right? And nothing changes in their medications, hemoglobin A1C, or anything like that. So in summary, functional dyspepsia, particularly of the postprandial distress subtype, and gastroparesis have very similar clinical profile, clinical outcomes, and most importantly, pathology. So instead of thinking of these two as distinct diseases, maybe we should start thinking of them as part of a continuum of pathology, what we call a macrophage-driven Cahalopathy. Difficult word to say, but we came up with it, and I still have a hard time pronouncing it. And also remember, we have shown, and others have shown this too, gastric emptying is unstable and hence not a reliable marker to distinguish these syndromes. So where is the dilemma? There's no dilemma. If you look at what we really want, better treatments, this is a study now almost 10 years ago that shows there's very little correlation between drugs and the improvement of gastric emptying and the improvement in symptoms. Now, more recently, Dr. Camilleri's group showed that, well, if you look at patients who have had an optimal gastric emptying, then you might see a better correlation between the improvement in emptying and the improvement in symptoms. So here on the right side is that paper. On the top is all comers, all kinds of gastric emptying, and on the bottom, his group selected out those with the optimal gastric emptying and showed that there was a significant correlation. However, and Dr. Camilleri is somebody I admire very much, a lot of respect for, but what they haven't emphasized in this paper is that 40% of these groups actually had functional dyspepsia to begin with, so their initial emptying was not normal, was not abnormal. So what does this mean? Let's go beyond this. Let's stop talking about this as if they are two distinct diseases. Let's start talking about gastric neuromuscular disorders instead. And this has real implications for the patients. Because if you think that they have the same disorder, and in 1 year, half of them will go from one to the other, then they are being denied access to trials or approved drugs just because gastric emptying at one single time point is normal. Or that gastric emptying is persistently normal, but their symptoms are the same and the pathology is the same, but they are told they have functional problems. But how do we even develop drugs? How do we even interest the pharma industry to invest in this field? We have seen over the last 30 or 40 years many attempts by pharma to develop prokinetics, drugs to accelerate gastric emptying. In the last 3 years itself, we've seen 3 or 4 drugs, and all of them have failed. None of them has made it to the market. So we need to stop doing the same thing over and over and over again because we are fixated on gastric emptying. We need to convince the pharma that it's not just about gastric emptying, that there are other symptoms that really don't depend on gastric emptying, like nausea, which are causing real problems to the patients and interfering with their quality of life. But most importantly, and this is something that I am very passionate about, having shown that these disorders all have the same pathology, which is an inflammatory loss of ICCs, we can now start for the first time to consider disease-modifying therapy that is directed at the underlying inflammation. And next year we will start a trial, a randomized controlled trial of a drug that attempts to do just that. So finally, we may be headed towards rational therapy, cures rather than symptomatic therapy. Because I am tired of telling this to my patients. There's no cure and there's not even a race for the cure. We must start the race. Thank you very much.
Muchas